All right, so good morning and welcome everyone. My name is Ellen Barra, and I am an analyst or a specialist with our Provider Outreach and Education Group of WPS Government Health Administrators. On the call with me today is my friend and colleague, Aline Ziegler, and Aline is going to be watching our chat for us. And we'll be placing information in the chat. And then when we get to the question and answer section, then she'll be funneling those questions and things to me. The first thing that we have is our disclaimer, and we use this with all of our presentations. We just want you to be aware that we have designed this presentation as a tool to assist you in billing appropriately to Medicare. However, as we're aware, Medicare rules do change often. So the CMS regulations, rulings, the information in the internet-only manual, etc., all of that is the final determinant of coverage. We will provide responses to the questions that you give us based on the way that you have asked the question. But again, Medicare rules will determine that final coverage. And then CMS does prohibit recording of this presentation for profit-making purposes. So if you're doing screenshots, if you're recording this, we would ask that you stop. We are recording this, and barring any technical difficulties with the recording itself, we will place this on our YouTube channel. In addition to that, it will also be placed on our website under the training center under an encore box, and it will be there approximately 60 to 90 days. And then of course it will be available on our YouTube channel until we take it down. So what we're going to talk about today are the global surgery rules and regulations and how they apply specifically to the podiatry specialty. We're going to talk about the global surgery period. We'll talk about services that Medicare deems to be provided as an inpatient only service as opposed to in an ambulatory surgical center, in your office, etc. We'll talk about the modifiers that may go along with the services that you're providing to your patients. Our objective here today is for you to really understand that global surgery concept with Medicare so that you can submit payable services correctly the first time and then get paid for those services. The next thing that we have is just a list of acronyms that we'll be using throughout the presentation. We've kind of gathered them all up in one spot so that you can use these as a reference. So the first thing that we want to talk about is a definition of the global surgery package for Medicare. And so how Medicare reimburses is one allowed amount for the surgical procedure that includes all of the preoperative work, the intraoperative work, and then the postoperative work. That preoperative work is going to be the evaluation and management services that you're providing within the global period, and we'll talk about that in a second. Your intraoperative work, of course, is going to be the surgery itself and anything that goes along with that. And then the postoperative work are any services that you're providing that are related to that surgery within that postoperative period. And the global surgery concept applies to that surgeon, the one who's actually doing the surgery, or a member of the same group with the same specialty. The IOM reference that you have there at the bottom, section 40, goes into all of that global surgery information, all of the exceptions to the rules, how the rules work, etc. So included services are going to be evaluation and management services that are related to the surgery. Now that's really going to be based on your diagnosis codes. So for an example, if you're doing a surgery to amputate a portion of the foot, maybe you have to remove a toe. But also during that global period, you're doing something to the other foot maybe trimming of nails or taking care of dystrophic nails, something along those lines. If that's not related to the surgery, then that means that Medicare can make payment for that. Post-surgical pain management is also considered part of the surgery allowed amount that Medicare has for the surgery. Treatment of complications, there's a couple of different things for that. If you're doing those services within the office, they are part of the global surgery package. If you have to return the patient to the operating room to treat those complications, then that can be an exception, and we'll talk in just a little bit about how you submit that. And then you can see, of course, dressing changes, suture removal, etc. Excluded services, one of the ones, first one there, is the E&M service that is the decision for a major surgery. And that decision is made either the day of the surgery or the day before. Now, when we're talking a major surgery, we're talking a 90-day post-op care surgery. And so really this is going to be a fairly quick decision when you're deciding that that patient has to have surgery. If you have decided maybe 3 weeks ago that you need to do surgery on this patient and you're scheduling the surgery, etc., any evaluation and management you do the day before or the day of is part of that surgery, because you really made, and your documentation will show that you made that decision for that surgery 2 weeks ago. Unrelated E&M, and we'll talk about the modifier that you need to use to show that it's unrelated. And again, that's going to be based on the diagnosis code. Return trip to the operating room for treatment of complications, and then clearly a distinct surgery. And there are modifiers that go along with all these that alerts Medicare to the fact that this is an exception to the global surgery package. So global surgery settings can be done in an ambulatory surgical center, at a hospital, either in or outpatient, critical care unit, or in a physician's office. The global surgery periods are listed for you here. You can see that we have 0, 10, and 90 days. Both 0 and 10 are minor procedures, and then the 90-day is the major procedure. Now, you'll notice on here that kind of secondary bullet point on each one of these identifies the days, the number of days that are part of the global surgery period. For a 0 day, it's actually 1 day, which is the date of the procedure. For the 10-day, it's actually 11, so it's the day of the surgery and then 10 days following. And for the 90-day, it's actually 92 days, the day before, the day of, and then 90 days following that procedure. Now you can find the global period for each of the procedure codes that you're performing for your patients by using this link that we have up on your slide. You can go into the physician fee schedule relative value file. You can go into your ribbon at the top and do a filter, and you can then search for your individual procedure code. You can also do a Control F and search for your procedure code. And then you want to go to the global days column, and then that will show you the 0, 10, or 90. You can also find in that column the X, Y, and Z. And X simply means that the global surgery does not apply. Your E&M codes are going to have an X. Your radiology services will have an X, just as 2 examples. The Y means that the contractor, such as WPS, will determine the global days that go along with that procedure. A lot of times these will be your NOC codes, not otherwise classified codes. And then for the Z status in that global days column, it means that this service is always included in something else. So whatever that something else is, that will determine the actual global period. For the global surgery billing guidelines, we have two documents or two resources available for you on our website. The global surgery billing guidelines includes the global surgery indicators, kind of the description of those, the rules behind that, and then it contains links to all of our fact sheets. We also have a date calculator available on our website. And what this will do for you is you can enter the date of that major surgery, and then it will respond to you with what the end date of that global period is. So it will just kind of help you determine that 90-day period. Here are the modifiers that we're going to be talking about today. The 24, 25, and 57 are all E&M, they go on the E&M services. And then the other modifiers listed there on the right hand of your screen, those are all of the modifiers that would go on your actual surgical procedures themselves. So let's start by talking about the E&M modifiers. You can see there modifier 24 is unrelated. Modifier 25, the definition there, significant, separately identifiable E&M on the same day as the procedure. And then again, the modifier 57, the decision for the surgery. So let's talk about these a little bit more. For your modifier 24, number one, it's going to be within that global time frame. So within that 10-day or 90-day postoperative period. If you're on day 91, you don't need to use a modifier 24 because it's not within that global period. So if on day 91, you're providing an E&M service to that patient and it is related to that surgery, it is still payable separately. It's outside of that global period. Again, 10 days or 90 days. These are for E&M services. They can also be used for the eye services, although as a podiatrist, you wouldn't be using those. You can also use a modifier 24 if your documentation indicates that your E&M is treating the underlying condition. So for an example, let's say that your patient has, you're providing surgery to that patient and you're removing a toe, okay, just as an example. However, what you're treating for that patient includes infection, not only where the toe is at, but also other infections or on that foot. It could also be treating peripheral artery disease for that foot, and that's what caused the toe to have to be removed. Your documentation will have to be real clear for that evaluation and management in the fact that it's not just a follow-up from the surgery, but it is treating that underlying condition. And then also for podiatry, the E&M is for a different anatomical site from the surgery. So you're removing the toe from the left foot, but you're treating the peripheral artery disease as an example, or treating another sore or something on the patient's right foot. So again, documentation is going to be key there. What we have up for you on this slide are some incorrect examples of modifier 24. If it's related to that surgery, such as you're treating that patient for an infection that's directly related, or pain that's related to that surgery. If you are sort of transferring through an incident to guideline, the follow-up care from the surgery to a non-physician practitioner in your same group, modifier 24 would not apply. You would be billing under your number since it's incident 2, And in billing under your number, it's part of the global surgery package. If you are transferring care to that non-physician practitioner, then they could bill separately for that. And I'll show you in just a second how they can do that. If the performing provider is a different group or specialty, you would not need to use the 24. If you're admitting the patient to a skilled nursing facility as related to the surgery, then you would not need to be using the 24 because it would be part of that global surgery package. And then additional services, labs and x-rays, etc., would not use this modifier. The next modifier that we have, I've lost my mouse, there we go, is Modifier 25. And I can tell you that everybody hates Modifier 25 because it is a very difficult modifier to understand and to really be able to evaluate your documentation to determine whether or not it is appropriate. So the definition of Modifier 25, as we saw previously, is a significant, separately identifiable E&M on the same day as a procedure. Well, what does this mean? Well, number one, significant means a great amount of additional work over and above what is normal with that procedure. That's going to go to your documentation. You saw the patient 2 weeks ago, you decided that you're going to do surgery, the patient comes back in today, an E&M service, unless it is significant and separately identifiable, is not going to be payable for today's service. In addition to that, it has to be separately identifiable. So what that means then is that when you're looking at your medical records, you can determine this part goes with the surgery and it's part of what your physician or practitioner would normally do for that patient. And then this part is the separately identifiable part. Now, the problem with Modifier 25 is that diagnosis makes no difference. If you have an additional diagnosis, Modifier 25 could or could not be appropriate. If you have the same diagnosis, Modifier 25 could or could not be appropriate. It's all based on your documentation. One of the conversations that multiple conversations that we've had with the provider community is talking about the automated use of Modifier 25. Well, you really can't do that. You need to look at the documentation and somebody needs to make a decision. Is this significant and separately identifiable from the normal E&M services that would go along with whatever procedure you're doing? What we're advising you to do is to perform a self-audit. Take a look at the last 3 to 6 months of your claims. If you're adding a Modifier 25 on every single surgery procedure that you have provided to that patient, it's incorrect. I can just tell you right now it's incorrect. Because what you're telling us then is this is what you normally do prior to doing the procedure. So the bottom line on this is, perform that self-audit. If you're identifying in looking at your documentation that the Modifier 25 is not correct on that service, then you do need to refund back to Medicare. Another way that the Modifier 25 is used incorrectly is as a decision for surgery. For minor surgeries, the 0 or 10 days, the decision for the surgery is part of the surgery. So the patient comes in today, you take a look at their foot and you say, oh yeah, we need to, to treat that wound. Well, unless your documentation is going into a lot more detail than that, and shows that great amount of additional work, then that E&M is simply part of that surgery. The second bullet point there, again, it's not based on diagnosis. It should not be reported with the 99211 procedure code. That's your ancillary staff code. And then the last bullet point there, this one gets a little bit confusing. According to the CMS guidelines, you don't have to append Modifier 25 on your new patient procedure codes, but the documentation is still required in your medical records should Medicare request it. The next thing that we have there is Modifier 57. This is the initial decision to perform the surgery, either the day before or the day of a major surgery. Now, you would not use this on critical care services. There's another modifier. However, critical care services and really the use of Modifier 57 are not as prevalent for podiatry as they could be for other types of specialties. So incorrect usage, well, you're not going to append it to the surgical code. You're not going to put it on an E&M when you have a minor surgery. And again, you want to be looking at your medical records to determine when did you actually make the decision for surgery. Did you make it today? And when you think about that, for Modifier 57, if you're going to make that decision today, you're doing that service today or tomorrow, it's a fairly urgent type of situation that you're going to have going on. That patient needs that surgery today or tomorrow. If your surgical procedure is indicating multiple sessions or stages, there are some procedure codes out there that actually have that within the description. Then an E&M service that you do before you do the second part or a session for this, you would not use the 57 on that because, again, you made that decision before you started these multiple sessions or stages. And then, of course, if you see the patient on Tuesday and decide they need surgery and they come back in on Friday, you don't need to add that Modifier 57 to the E&M on Friday because it's not within that global surgery package. Again, for 0, it's the day of. For 10 days, it's the day of and 10 days after. For major surgery, the 90 days, it's the day before, the day of, and then 90 days after. So the next list that we have for you there are the surgery modifiers. These are modifiers that are going to go on the surgical code itself, and we'll go into the explanation of those as we continue on. But you can see there Modifier 54 is the surgical care only. 55 is postoperative only. 58 are those staged or related procedures. That goes back to those multiple sessions we talked about. 78 is an unplanned return to the operating room by the same physician or same person or same specialty within the same group. For treatment of complications during that postoperative period. And then Modifier 79 is an unrelated procedure. So let's talk about Modifier 54. Well, this is when the surgeon is performing the surgery only. They're not going to do all of the postoperative care. They could do part of it, or they could transfer that postoperative care to somebody else. When you bill for this, you're going to bill the surgery procedure code and surgery date of service and Modifier 54. The other person to whom you have transferred that postoperative care, that person is going to bill a different modifier, the 55, which we'll talk about in just a second. If you are keeping part of that postoperative care, but then relinquishing it to another provider to complete that follow-up care, then you'll have actually 2 lines of service, one with a 54, one with a 55, and we'll talk about 55 in just a second. On your claim, you need to identify the date that you transferred that care to somebody else. So let's talk about a situation where that could apply. As the podiatrist, you could be providing a surgical procedure to that patient, and you're going to transfer that postoperative care back to the primary care physician as an example. Well, that's when you would use 54. If you're transferring that care to a non-physician practitioner within your office and you want to bill for that, then you would use the 54. The non-physician practitioner would use the 55. So here's some examples for you of incorrect. If you're keeping that patient for the entire post-op care, obviously you don't need to use this. If the global days are 0, you don't need to use this. And then it does not apply to the ambulatory surgical center itself. Now, if you have provided this in an ASC, when you're billing your services, it would still apply, but it doesn't apply to the ASC billing itself. And then, of course, it doesn't apply to an assistant at surgery because their payment is very different from global surgery. So now let's look at 55. So if you're the practitioner who's receiving this patient and you're going to take care of the post-op, but you did not do the surgery, that's when you're going to use 55. You're going to report the surgical procedure code as your billing code, and then you'll also report the date of service as the date of the surgery. Now, on your claim form, you're going to indicate when you assumed that care. Couple of things to think about here. Number one, if the surgeon says, I'm relinquishing care on 5/14, you would then assume care on 5/15. If those dates overlap, then that could cause a denial for Medicare. You also cannot bill this until you provide at least one service, generally going to be an E&M service, to that patient. And then again, submit with the surgery procedure code and then 1 unit of service. What Medicare will do there is we will evaluate when you assumed that care for the patient. You'll identify the number of days, and then Medicare will prorate that post-operative payment based on the number of days, and then that would be your allowed amount. Incorrect usage of code, of course, if no one transfers the patient to you, then you would not be using this. If the surgical code has a 0 indicator for the post-operative time, you would not use it. And then this would not be used on an E&M service. If you're being transferred post-operative care, again, you're going to bill that surgery procedure code. So here are some of the common errors: not using the surgery date as the date of service, not including that assumed or relinquished dates and the number of days on that claim. There's no documentation of a transfer agreement between that physician who's providing the surgery and that physician then who is accepting that patient. And then unfortunately, the biggest one that we see is that the surgeon does not include the 54 modifier. And therefore, when the next physician is billing the 55, Medicare will probably deny that. You'll need to request an appeal. We will then have to go back to that surgeon to find the transfer agreements, when they relinquish care, etc. The next modifier that we have also goes on your surgical code. And this is when you have a planned or staged service. So you're looking at, again, we'll go back to the patient's toes. Your plan is that you're going to remove a portion of this toe, and we're going to see, you know, within a short amount of time, do we have good tissue color? Do we have still a lot of pus and everything coming out? So our plan is we're going to do this partial amputation, and then if that doesn't work, if that doesn't take care of the problem, then we're going to do the full amputation of that toe. It can also be used when you're doing a more extensive procedure than the original procedure that you did. Now for podiatry, I don't have an example of this, but as an example that I think we all can relate to, if we do a lumpectomy, like in the patient's breast, for an example, and then that doesn't take care of the situation, and now we're going to have to do a full mastectomy. So that's the surgery we're doing now is more extensive than the original one that we did. And then therapy following a diagnostic or surgical procedure. So an example of this one could be that we kind of did a diagnostic procedure and we're evaluating that toe. We're looking to see and you know, using our surgery services, looking to see how in depth that wound goes. We're doing a debridement, we're scraping off, or whatever we're doing there. And then we're having to do a therapeutic removal of that toe. So if the second surgery, the removal of the toe, is within the postoperative period of the first surgery we did, that's when you would use Modifier 58. And you'll notice here that last bullet point, a new postoperative period does begin when you're using that Modifier 58. Incorrect uses, again, an ASC is not going to use this. Your assistant at surgeon is not going to use it. Unrelated procedures during the postoperative period or the treatment of a complication. And that's the one we'll talk about next. This is Modifier 78. So the situation that you have is you provided a surgery to the patient, but they have developed some type of complication from that surgery. And in order to treat that complication, you're going to have to take that patient back to the operating room. So it's not something you can do in your office. It really requires a specialized room that is designed for that. So you can see those listed: operating room, laser suite, endoscopic suite, etc. You can, if you are doing the same service to treat that complication as the original procedure, that's fine. You're going to bill whatever it is that you're doing, and then you append that Modifier 78. Modifier 78 does not start your global period over again. So what Modifier 78, this is a payment modifier. It only pays for the intraoperative portion of that global surgery package. Incorrect uses, if you're having to take that patient back to the operating room for a complication, but it's outside of the global period, then you don't need to use the modifier. If you're not going to an operating room, you would not use this modifier. If you're doing a service within your office, it is simply part of that global surgery package. The next one that we have then is Modifier 79. And this one is an unrelated procedure performed during that postoperative period. So in this situation, it could be that your first surgery, you had to remove the left pinky toe. And now you're going to have to go back in and you're going to have to remove the right pinky toe. Well, those are not related. Those are different anatomical sites. Therefore, if you're doing that second toe within the postoperative period of the first toe, that's when you would use modifier 79. Again, you want to pay attention to your global surgery periods between those services that you're providing to determine if it's appropriate. And then that last bullet point there, modifier 79 does start that postoperative period over again. Incorrect uses, you could see here, just some examples. You're not going to use it on an ASC facility claim. You're not going to use it if you're outside of the postoperative period, and you don't need to use it if you're not the same surgeon or a member of the group with the same specialty. We also have the laterality modifiers listed for you here, and the links will take you to the fact sheets. So when you have an LT or an RT, this is when there's actually a left and right side of whatever area that you're actually addressing. You want to use it when there's no more specific modifier that could apply, such as the T modifiers, for an example. Incorrect usage is going to be there aren't two sides of the body for this, wherever it is that you're looking at, or your procedure code either indicates both right and left, or the procedure code is identified as bilateral within the actual description or within the relative value file. For modifier 50, this is when you're performing the same service on both sides of the body during the same operative session. You want to look to make sure that you can use modifier 50, and again, that's in that relative value file. And then when you submit it using the modifier 50, you submit with 1 unit of service. Now, this may be different than what the CPT instructions are, but Medicare's instructions are this way based on payment. Modifier 50 is a payment modifier, so you do submit it all on one line with only 1 unit of service. Incorrect uses is where your procedure codes already indicates that it's bilateral, or it's different areas of the same side of the body, or a situation where the relative value file states that you can't use this. Here's the information as to why we instruct providers to submit on 1 line of service. In the relative value file, you can see the indicators there for bilateral. The 0 does not apply. The 2, the 150% payment does not apply. And the 9, bilateral payment doesn't apply at all. It's the 1 that necessitates billing as the instructions that I gave you. What we do in this situation is we allow at 150% of the Medicare allowed amount for that bilateral procedure. So you're getting an additional 50% when you're indicating that modifier 50. For what happens a lot of times, number one, if you're billing on 2 lines, I think the last time I looked at the CPT instructions, it said bill 1 line and then 1 line with the modifier 50. Well, in that situation, you're really telling Medicare that you did 3. And, you know, when we're talking about services on the feet, Medicare is going to want pictures. You know, we're going to need additional information on that one. But this is the reason why we give you those instructions. For the digit modifiers, you're going to identify the procedure for the specific digit and then submit it with that digit modifier. Incorrect uses, if you're doing something on the heel, obviously your digit modifiers would not apply, or if your procedure code itself indicates that it's multiple digits. And then the next thing that we have is medically unlikely edits. We've given you the link to the file for the medically unlikely edits. You do want to pay attention to the fact that it is updated quarterly. So you want to be looking at the MUE file for the quarter in which you're doing the service. Now, there can be situations where you can go above what is listed within the MUEs, and you can see those adjustment indicators. The one may require a modifier, and specifically, this would probably be one of your digit modifiers. For a 2 indicator, Medicare simply not going to allow more than the MUE. And for a 3, you would need to appeal and provide us with documentation as to why you had to go above that medically unlikely edit. The next thing that we have is the National Correct Coding Initiative Procedure to Procedure Edits. We provided you a link there on how to use that particular tool. When you're looking at that, you're going to find 2 columns of procedure codes. The first column is the payable code. The second column is the code that's going to be denied unless there's an exception. So this could be where you're, where you're using a digit modifier. You could be using an RT or an LT type of situation. If there's no other modifier that could apply, you could be using one of the X modifiers or the 59 modifier. You just want to make sure that your documentation is supporting that this really is a separately payable service. So the next thing that we're going to do then is open this up for questions. And I did have one pre-submitted question on Modifier 22. Modifier 22 is not a common modifier for the podiatry specialty, which is why we did not include it in here. However, Modifier 22 tells Medicare that the service was extraordinary in some way. It was more complex. When submitting this claim to Medicare with your procedure code and Modifier 22, there are 2 pieces of information that you need to include, and providers are missing a lot that second piece of information. The first one is the operative report, and the second one is a statement indicating why you believe you should receive additional monies for this. So in that statement, you can point us to the section of the operative report that shows how this service was extraordinary, how it was not, how it was a bigger service, how it was not just what the procedure code actually would indicate, but you have these additional things going on. So you need both of those. You can submit those with your claim. If you're submitting electronically, you can use the PWK segment. In addition to that, and this is another reason why we don't do anything with the Modifier 22, is you want to make sure that you've increased your billing. If you're billing to Medicare and you're billing us the allowed amount for that procedure code, we don't have any room to pay you anything more based on your billed amount. So therefore, we won't evaluate any of the information you've sent for Modifier 22. We can't do anything with it anyway. So if you believe you have a situation where Modifier 22 would apply, also, submit those 2 pieces of documentation and then also look at your billing amounts. So Aline will go ahead and open it up for questions.
Thanks, Ellen. That was a lot of great information. The first question that came into us today is from Sarah, and she says, if you have a patient coming in for wound debridement, but now has cellulitis labs ordered and needing medication to treat, would that warrant a separate evaluation and management if the work was documented?
Okay, that's not a question that I can answer for you, because that would be a modifier 25 situation if you're doing it on the same day as the debridement, and you really need to look at your documentation. The fact that it's a different diagnosis does not mean modifier 25 is appropriate. It could also be that you have a same diagnosis and modifier 25 is appropriate. What you want to look at is what work does your physician or practitioner normally do prior to doing the debridement. If they have done more than that and that work is significant, and someone looking at the documentation can say, this part goes with the cellulitis, this part goes with the debridement, then yes, modifier 25 could be appropriate. But you really want to be looking at documentation. Next question.
And Ellen, that was actually the last question that we have today.
Okay. So on behalf of Aline and myself, we want to thank you very much for your attendance today, for taking time out of your day to listen to this information. We hope that this information is very valuable for you so that, again, you can submit claims correctly and get paid appropriately by Medicare. I do encourage you to take the survey. We want to hear your feedback. We want to know if we're giving you and providing to you the information that you want. So on behalf of Aline and myself, we want to thank you very much for your attendance, and you can now disconnect. Have a great day, everyone.